All right. Chapter 47, Head and Face Trauma Part 2. We left off with the eye, I believe, so we're going to pick up with the ear. Um, soft tissue trauma certainly can occur to the ear, particularly in sports. We used to see a lot of ear avulsions in rugby. You have the external outer ear, which is the auricle, and it's the pinna that sticks out from the head, and then the external ear canal. So there's the auricle and the pinna, and then the external auditory canal. And then when you get inside the ear, you've got the tympanic membrane. And then just beyond the tympanic membrane, you have the multiple structures that take the sound from the membrane and transmit it to the eighth cranial nerve, and that sends those sound impulses to the brain where they're interpreted. And you can see this part right here called the cochlea. And if a person who's had a cochlear implant, you'll see a device that sits on their head with wires that go inside their head to their brain. And the cochlear implants will help some people with deafness hear. Other parts of the external ear include the tragus, the lobe, the antihelix, the antitragus, the helix, and the concha. The tragus is important because that's a landmark we use when lining the airway up, particularly on children. We talk about the tragus being able to point parallel with the child's shoulder, so that we know the airway is in a neutral inline position. The middle ear is the hollowed out area of the temporal bone. It transmits vibrations of tympanic membrane across the middle to the inner ear. It's lined with mucous membranes filled with air. It's separated by the eardrum and the tympanic membrane. Here, looking in through a ophthalmoscope, you can see the tympanic membrane, and normally it should be relatively clear. And I do see some of that, but you see some red in there, and so that could be a damaged tympanic membrane, and there could be a little blood behind the tympanic membrane. When those ruptures, it's obvious because you'll see a hole in that tympanic membrane. The middle ear consists of the ossicles, which has linked and movable bones. The ossicles transmit vibrations from the tympanic membrane to the oval window, which separates the middle from the inner ear. Eustachian tubes are important for draining fluid out of the ears into the throat. The ossicles opens into the middle ear, connects the middle ear to the pharynx and the respiratory system. No, that's the eustachian tube. The eustachian tube opens into the middle ear, connects the middle ear to the pharynx. It also helps equalize pressure between the air outside and the air within the middle ear. So when you're pinching your nose and trying to equalize the pressure in an airplane or going down a really high hill or up in the mountains, you're forcing air through your eustachian tubes. The inner ear is fluid-filled tubes within the temporal bone. You have the bony labyrinth. Sound vibrations are transferred to the inner ear. They become fluid waves in the cavity, lined with periosteum and filled with clear fluid. These hair-like structures bend and flex in response to sound wavelengths. And then nerve impulses generated in the inner ear travel along the vestibulocochlear nerve, or the eighth cranial nerve, directly to the brain. You can have blunt trauma to the ear, penetrating trauma to the ear. With blast injuries, the pressure wave from the blast will rupture the eardrum. And so if you're at the scene of a blast injury and a person complains of not being able to hear, then you can suspect that they've ruptured their eardrum as a result of the blast wave. But more importantly, that same sort of blast wave then was applied to any cavity in their body that's filled with air. So they could have, a pretty significant pulmonary contusion. They could have what's called blast abdomen from air-filled intestines rupturing, and a mild traumatic brain injury. Pressure injuries to the ear include not being able to equalize the pressure. So as an example, divers, if their eustachian tube is plugged, they're often taught to take antihistamines before diving to ensure that might be dried up. Because if that's plugged and they're unable to equalize the pressure as they go down, they can actually rupture their eardrum during a dive. As far as the etiology and the demographics of ear trauma, you can have outer ear lacerations. You can have ear hematomas from sports or falls. You can have a ruptured eardrum from being slapped upside the head with a closed hand. The external ear, of course, is prone to injury from temperature extremes as well, sunburns, frostbite, those sort of things. The external ear canal and middle ear assessment cannot be done in the field because we don't have an ophthalmoscope. But if somebody has a ruptured eardrum, as we had mentioned, they may not be able to hear. They'll complain of sharp pain in their ear. They may be dizzy. There may be blood draining from the ear. If somebody's got an ear infection, sometimes the pus will build up back behind the tympanic membrane, and the pressure will cause the membrane to rupture, which relieves the pain of the ear infection, and you'll see that built up fluid drain out their ear. ABCs come first. If the blow is significant enough to the side of the head, consider or rule out the potential for spinal trauma. For lacerations, we control hemorrhage like we do any other method with direct pressure. We're not going to aspirate a hematoma in the field. There'd be no reason for that, but typically that's what a person might do if there's a large hematoma and it's just to stick a needle in it and aspirate the blood out of it. If we've got a suspected cerebral spinal fluid leak out of an ear, we would want to put a loose dressing over the ear to capture the drainage, but we wouldn't want to pack it tight. As far as the neck, you have different zones in the neck. Zone 1 is between the cricoid cartilage and extends to the clavicle and the sternum. Injuries in the neck, of course, are of highest priority because of the potential for not only spinal cord damage, but you've got some pretty significant structures in your neck, including your carotid and vertebral arteries, your subclavian veins, your brachiocephalic veins, your jugular veins, your aortic arch, not to mention your thyroid and parathyroid glands. Zone 1 also includes the lungs, the trachea, the esophagus, the thoracic duct, the cervical spine, and the spinal cord. Zone 2 is between the table of the mandible and the cricoid cartilage. Within that zone are the carotid and vertebral arteries, the jugular veins, the pharynx, the larynx, the trachea, the esophagus, the spinal cord, and the cervical spine. Zone 3 is above the mandible angle, and in zone 3 would be the carotid vertebral arteries, the jugular veins, the salivary and parotid glands, the esophagus, the pharynx, the trachea, cranial nerves 9 through 12, and the cervical spine and spinal cord. So here is just all that anatomy that they discussed. They don't have it divided into different zones in this particular diagram, but you can see that injuries to the neck can cause extensive hemorrhage from all the vessels. In addition to extensive hemorrhage, you also can decrease a significant blood flow to the brain. There we go. There's your zone 1, zone 2, zone 3. You can have blunt neck trauma from motor vehicle collisions, where the trachea and the larynx are compressed against the cervical vertebrae when you're not wearing shoulder belts. You can have anterior chest injuries that could damage the neck in sports, clothesline injuries, which may cause a separation of the larynx from the trachea, strangulation injuries, which may crush the thyroid membrane, which is where the vocal cords are housed. You can have penetrating gunshot wounds to the neck, stab wounds to the neck, lacerations and puncture wounds to the neck. What we're seeing come out of neck trauma, particularly penetrating trauma from these things, is that if the patient has no obvious signs and symptoms of spinal cord damage, in other words, pain, numbness, tingling, paralysis, then there is absolutely no reason to board and collar somebody like this. Research has shown that those patients who were bored and collared actually had poorer outcomes than those who were just placed on the cot. And they believe that to be the result of perhaps not paying attention to the important things like controlling hemorrhage and occlusive dressings to prevent an air embolism and those sort of things. 10% of the people with blunt vascular injuries develop symptoms within the first hour. The larynx and tracheal compression will cause vocal cord swelling and bruising. You'll see a normal airway landmark disruption. In other words, the Adam's apple, may be abnormally positioned. You may even see some soft tissue swelling or hematomas in the neck as well. Injuries to the trachea is going to lead to subcutaneous emphysema, coughing up blood. There may be actual open wounds. Because the esophagus sits directly behind the trachea, as you're looking straight on, the esophagus could be damaged as well. And then, of course, you always have the potential for cervical spine trauma. History and physical findings, you're going to have swelling, lacerations, puncture wounds, soft tissue discoloration, obvious deformity. Neck veins may be normal. Accessory muscles may be used in breathing. You may have respiratory distress signs, particularly if you've got some narrowing of the upper airway or partial obstruction of the upper airway from a hematoma or swelling from soft tissue injury or crushed larynx, those sort of things. You may feel crepitus, subcutaneous emphysema. The trachea may be out of position, which might lead you to believe you're dealing with perhaps a tension pneumothorax, and it's caused a mediastinal shift, but it could be just from, again, things like a hematoma. Sucking neck room, I'm not sure. I think that might be a misprint. I'm going to have to look that one up. Some history and physical findings. The patient may be pale or cyanotic, have bruising of the neck, redness of the neck. May also have petechiae. I don't see that here, but in strangulation injuries, they will develop petechiae on the neck as well. You may hear a sucking, hissing, or air frothing through a neck wound. And again, the importance there is that if the wound opens a vessel up, particularly one of the larger vessels, as blood flows by that opening in the vessel, it'll pull air into the system, and you can get potentially large and lethal air embolus. Subcutaneous emphysema may be present. Hematoma may be present. They may be actively bleeding. They may be working hard to breathe. They may not be able to speak. Their cough may be weak. If you listen in the neck, they may have a thrill bruit, which is a whoosh that you hear in the carotids when they're narrowed. And, of course, they may be in shock. Some other signs include stridor, which indicates upper airway obstruction, which is an inspiratory noise. Signs of paralysis, paresthesia, or neurogenic shock if it's a high level cord injury if the spinal cord is involved. Signs of stroke with an air emboli. So, that's one of the big concerns of making certain that we seal a neck wound with an occlusive dressing as soon as we can so that we prevent that air embolus from getting into the bloodstream and going up into the head. Some other symptoms of neck trauma would include voice changes, tickle or a feeling of fullness, cervical pain, weakness, numbness, hoarseness, difficulty breathing, difficulty swallowing. And here they're just showing you, how to do an assessment for position of the muscles, presence of a hematoma, position of the trachea, the feel of the Adam's apple or the larynx. You want to get a sample history, noting the mechanism of injury, their level of consciousness, any drug or alcohol use. We're going to treat life threats first, consider cervical spine immobilization, control hemorrhage. Be on the lookout for pharynx, larynx, tracheal, epiglottis, and vocal cord swelling because as that soft tissue swells, it's going to narrow the upper airway, and you may initially hear a hoarseness or a hot potato voice, and later you may hear things like stridor. As far as intubating something like that, the old adage is, if you get in there with a laryngoscope and everything is so swollen and all you can see is maybe a pool of spit and they're still breathing, look for the bubbles because that's probably where the trachea is. If you have a complete upper airway obstruction, you need to do a cracothotomy, either surgical if you're a critical care paramedic or a needle cracothotomy if you're a paramedic. Again, open wound, you want an airtight dressing. Hemorrhage, you want to provide direct pressure to the vessel itself, gain vascular access en route to the hospital. You want to put your IV on the opposite side of the injury and then rapid transport. I'm going to talk about head trauma. We'll start first with the scalp. The scalp does an amazing job of protecting the head, not only from invading organisms, but because it is skin, it does help regulate body temperature. There's a certain percentage of heat that just goes right out our head. It keeps the extracellular fluid from being lost to evaporation. It's a place for hair to grow. It does come in layers. And the other more important thing about the scalp is that it slides. If you place your hand on your scalp and move it back and forth, you can feel that your scalp does slide across your skull. And it's this sliding mechanism that allows the scalp to absorb a significant amount of force. In fact, it's estimated that it takes about 350 pounds per square inch to lacerate your scalp, where it only takes about 70 pounds or 75 pounds per square inch to fracture your skull. The skull is made up of facial bones, cranial bones. You've got that roof-domed shape that protects the upper brain, which is made up of the frontal bones, the parietal bones, the occipital bones, and the temporal bones that are fused together. The middle meningeal artery runs directly under the temporal bone. In fact, you can feel it when you palpate over the area of your temple. You can palpate that middle meningeal artery. And the importance of even bringing this up is that when a person takes a blow to the head and has a depressed skull fracture of the temporal area, it's likely that middle meningeal artery is torn, and you end up with an epidural hematoma or an epidural bleed. And that epidural hematoma carries a relatively high mortality rate because it is arterial, and it has a classic presentation. Blow to the side of head, loss of consciousness, regain consciousness, and then lose consciousness again. The foramen magnum is the only opening in the skull. It's at the base of the skull, and it allows the spinal cord to become the brain stem. So here is all those areas of bone and connective tissue, and then that's just the bone and the scalp and the bone. The meninges are 3 layers of protective tissue that surround and protect the brain and the spinal cord. The spinal cord has meninges over it as well. They include the dura mater, which is Latin for tough mother. That is the thickest layer, and I liken the dura mater to the silver or the membrane on ribs. If you've ever tried to pull that membrane off the back of ribs prior to cooking them, that's a tough pull. And that has a tendency to contain the cerebral arteries. The arachnoid membrane is called the arachnoid membrane because it's very loose connective tissue that pretty much looks like a spider web. Now the arachnoid membrane, because it is very loose connective tissue, looks like a spider web. It has a tendency to contain the cerebral veins as well as cerebral spinal fluid. So the arachnoid membrane is a very protective area, but when trauma occurs deep into that membrane, then the ruptured vessels could be venous bleeds, which are sometimes very slow to occur. So here are the bones of the skull and the face. You've got the 2 frontal bones, 2 parietal bones, 2 temporal bones, 2 occipital bones on the skull, and then you've got the foramen magnum, which is the big hole in the base of the skull there, and then you've got we've already covered all the bones of the face when we talked about trauma to the face. Here they're trying to show you the different vessels, cerebral veins, cerebral arteries, in relationship to the skull and the dura and the arachnoid and the pia. The pia mater they didn't even mention. The pia mater fits on the brain itself like a tight glove. So it fits into all the convolutions and squiggles of the brain and isn't in contact with the arachnoid membrane all the time. So that subarachnoid space exists, and that's where vessels are, and that's where bleeds do occur. CSF is a clear, watery fluid that circulates beneath the arachnoid membrane. It bathes the brain and spinal cord. It does provide a cushion during trauma in absorbing traumatic force, and it also provides nutrients to the brain and spinal cord. Bleeding in that subarachnoid space can be rapidly fatal, as we'll talk about. Now here they're talking about the pia mater, which coats the crevices and cavities of the brain and the spinal cord. Mechanisms of injuries that can cause head trauma include motor vehicle collisions, falls, abuse, impaled objects. Cranial vault fractures are more common than the basilar skull fractures. Skull bone fractures are related to the responsiveness level in the patient. And I'm not sure what they're trying to say there, other than, if you have a linear fracture, which is a crack, those patients may have headaches. On x-ray, you may see a little air inside the head. And if air can get inside the head, then so can germs and bugs. And the big issue with linear fractures is the potential for an abscess. Basilar skull fractures, we know, fracture the base of the skull, the floor of the skull that the brain sits on, and oftentimes cerebral spinal fluid can leak out the nose and ears if the sinuses are ruptured and the eardrums are ruptured. You can have soft tissue or bony structure injury from both closed or penetrating trauma. This slide is trying to illustrate to you the concept of a coup contra coup injury. And in a coup injury is a direct injury. So I slam on the brakes and my head flings forward and smacks on the steering wheel. I'm going to have some bruising and damage to the front of my brain. But then when I recoil and rebound backwards, then the backside of my brain, it may hit the irregular surfaces of my skull and cause a damage on the back of the brain, sort of an indirect injury. So you can have a coup contra coup brain injury. In other words, contusions, bleeding, both front and back, following a smack to the front of the head. Here they're trying to illustrate bone fragments that in a depressed skull fracture may penetrate the brain tissue, causing brain damage, but also arteries and veins can be torn, leading to bleeding and edema. As far as more etiology and demographics concerning head injuries, you can have an avulsion, which is a flap injury to the scalp. And remember that if you see a significant scalp injury, you know that it took a great deal of pressure to create that, and the skull may be fractured below. And we already talked about there being linear fractures, which were cracked, depressed skull fractures, which should be highly suspicious for brain bleeds, basilar skull fractures, the base of the skull, and we know that from the evidence of raccoon's eyes and Battle's sign. And then skull fractures can be comminuted, multiple chunks of bone, or they can be compound, where there's actually a fracture that leads to an open hole in the skull. With head trauma, you want to manually stabilize the cervical spine until you can rule out the need to completely stabilize them. You're going to find your depressed and open skull fractures on palpation, particularly if they have lots of hair. Linear fractures, you're not going to see those, but you may see bruising and swelling of the soft tissue that could indicate the presence of a fracture underneath. DCAP BTLS or DCAP BLS TIC, those are just the things that you're looking for as you're assessing that scalp and skull. They recommend using your finger pads for palpation, as you might get a better feel for depression. With infants, remember that their bones aren't fused together, so they're going to have fontanelles that are open or soft spots. Look at those following a head injury to see if the fontanelles are bulging. If they're bulging, that would be a good indicator of a rise of ICP. Scalps are vascular. You lacerate the scalp and you can have some significant bleeding, and we're going to control that like we do any bleeding with direct pressure. But we do have to be careful with the pressure, particularly if there's a depression of the skull under that scalp laceration. Check the ears for Battle's sign and clear fluid or blood coming out of them. Palpate the skull and scalp for tenderness and pain. Inspect the face and the eyes for the DCAP BLS. Anterior fossa fractures. The signs and symptoms of an anterior fossa fracture include epistasis or a bloody nose, CSF from the nose, the absence of smell, raccoon's eyes, visual disturbances, and a subconjunctival hemorrhage. So here is the cribiform plate. The cribiform plate, I was trying to see what do I recognize about this. This is looking at the base of the skull, or the cranial vault at the base of the skull, and the cribiform plate is something that where the nose reaches the hard palate, or at the very back of the nose or the roof of the nose is the cribiform plate, and that can be fractured, particularly if there's trauma to the nose, upward trauma to the nose, And the potential for perhaps if you put a NPA in, there's always that potential that the NPA could go into the head. Now, I know you may have all been taught that if you've got severe maxillofacial trauma that you don't put anything in their nose, and that's just not true. There was one case reported in the history of medicine where a nasogastric tube, which is far firmer, quite a bit longer and larger than a NPA, was placed in somebody with severe maxillofacial trauma, and it did go up through the cribriform plate into the brain and coiled up inside the head. And if you ever get an opportunity to see that slide, I haven't seen it in years, but when I did, it's impressive. And from that one individual event came the order that if somebody's got severe maxillofacial trauma, you shouldn't put anything in their nose. If an NPA is what's necessary to open their airway, you could take that risk. The middle fossa, you'll have CSF draining from the ears, maybe some hearing loss, bleeding behind the tympanic membrane, soft tissue discoloration behind the ears, which is known as Battle's sign, and then perhaps even facial nerve injury. And here they're showing you that middle fossa and the structures of the middle fossa. More structures of the backside. You see this in red. That's what we're looking at here. And if we go back to the middle fossa, that's what we're looking at here. And if we go there, this is what we're looking at here. So this is the cranial vault. This is the underside. This isn't what the brain sits on. The brain sits on the backside of this. Okay? But it is divided into different sections, and depending on which section is fractured, determines what you might see. So with head trauma, some of the therapeutic interventions include cervical spine precautions, monitor the airway, because certainly with head trauma you can have abnormal breathing patterns, you can have trismus, which is lockjaw. Don't insert a tube through the nose, and that's not necessarily true. Depressed skull fractures, cover with a sterile dressing, but don't put a lot of pressure on them because you could push those bone ends further into the brain. CSF fluid drainage, cover with loose sterile dressing. Again, we don't pack the nose or the ears, and that's probably a good thing to have those that CSF run out of there. It's gonna place the patient at greater risk of developing an abscess or something like that later. But those cracks in the base of the skull will they'll eventually heal. What's more important is by CSF being able to leak out of the cranium, we're able to help decrease intracranial pressure, because there's a place for that pressure to go. If you've got exposed brain tissue, put a wet sterile dressing over it and transport to a neurosurgeon. The brain consists of the cerebrum, which is divided into a left and right hemisphere, and each hemisphere has 4 lobes named after the bone above it. So you're going to have 2 frontal lobes, you're going to have 2 occipital lobes, you're going to have 2 parietal lobes, 2 temporal lobes, and it's the cerebral cortex, or the center of the brain, that controls voluntary movement. So here is an example of the cerebrum, and you can see the purple part in here is the purple and green part here is the cerebral cortex, where you have the diencephalon, and what's in here are things like the hypothalamus, those sort of things. And then you have the brain stem, which is made up of the pons and the medulla oblongata, and the brain stem is responsible for all your vegetative functions. And then you've got the cerebellum. And the cerebellum is a little brain, sits back here, and the cerebellum is responsible for all your fine motor skills, balance, threading a needle, those sort of things. Also of note in here is the RAS, the reticular activating system, which determines your level of consciousness. Here are the four lobes, the frontal lobe, the parietal lobe, the occipital lobe, and the temporal lobe, and then what those lobes are responsible for. And if you have an idea of what those lobes are responsible for, and those are the type of neurologic deficits that you're seeing, then you might know where the injury is on the brain. The diencephalon in there, in that cerebral cortex, in that diencephalon, is the thalamus, which is the relay station or the switchboard. It sorts out all your sensory information and routes it to the brain for processing. And then the hypothalamus controls things like vomiting, regulates your temperature, your water balance. The brainstem connects the spinal cord with the higher brain structures. It includes the midbrain, the pons, the medulla oblongata. It contains the nuclei for most all your cranial nerves. Coughing, swallowing, respiratory rates, heart rates, regulation of the blood vessel diameter is all controlled by the brainstem. The cerebellum controls fine motor movement, as I said. It coordinates skeletal muscle movement and balance. The reticular information, or the reticular activation system, the RAS, is a collection of nerve cells that helps you maintain attention and maintain wakefulness. You stop simulating that reticular area of the brainstem, and you'll go to sleep. That's why most people, when they try to go to sleep, like it quiet. They like it comfortable. They like it dark, so that they're not stimulating that reticular activating system, and they're able to go to sleep. The cerebral ventricles connect to each other, and the subarachnoid space that surrounds the central nervous system, and the cerebral ventricles on a head CT at some point look like a butterfly, and those are filled with CSF, and CSF drains from those cerebral ventricles into your abdomen. CSF, cerebral spinal fluid, is formed by the choroid plexus in the ventricles. It flows around the brain, through the spinal cord, through the subarachnoid space. It is reabsorbed from the subarachnoid space and enters the venous bloodstream. I guess what I was referring to earlier is that in people who make excess CSF and may suffer from hydrocephalus, they'll put a shunt in the ventricles, and that shunt will go down into the abdomen and drain that excess CSF into the stomach. The brain is it's a pig. It consumes at times up to 60% of all your sugar and oxygen. Under normal circumstances, without high function, it receives 15 to 20% of all your cardiac output and 20% of all your oxygen. It gets its blood supply from the vertebral carotid arteries, and within minutes of oxygen interruption, we're going to start to see brain cell death, which is going to affect mental status and start to affect vital signs, as we'll talk about. Now, some things to keep in mind, or concepts to keep in mind about the anatomy of the brain. We know that the skull is a rigid, inflexible box that does not give, and it only has one hole in it, and that's the foramen magnum. Now, if we look at what's in that cranium, the brain occupies 80% of the space, blood and blood vessels occupy 10% of the space, and CSF occupies the other 10% of the space. So there's no room inside this rigid, inflexible box that does not give for anything else. And when we have brain swelling, when we have brain bleeding, that's going to take up space and cause intracranial pressure to rise. Now, the importance of that concept is that the brain has a blood supply like all organs do, and the brain's blood pressure is known as cerebral perfusion pressure. And normally that's somewhere between 70 and 90 millimeters of mercury. It's the pressure of the blood filling the brain, and it can be determined by taking your MAP, your mean arterial pressure, which is the average pressure in the arteries all the time, and subtract from that any rise in ICP. Now, MAP can be determined by taking the diastolic plus 1/3 of the systolic minus the diastolic. So let's take a blood pressure of 120/80. My MAP would be 80 plus 1/3 of 120 minus 80. My MAP would be 80 plus 1/3 of 40. So my MAP would be 80 plus 13. So my MAP would be 93 millimeters of mercury. And in reality, the brain needs at least 60 millimeters of mercury to perfuse itself. Normal perfusion is 70 to 90. But from that MAP of 93 that we got, we have to subtract from that any ICP. And normally, your intracranial pressure is around 10 to 15 millimeters of mercury. So my blood pressure of 120/80 gives me a MAP of 93, but then I have to subtract from that, we'll say 10 millimeters of mercury to account for my ICP. So now I have a MAP of 83. The concept I want you to get here is that if just 6 milliliters of fluid is introduced inside your head, it can cause the ICP to go to 150 millimeters of mercury. When you cough forcefully, your ICP shoots up to 40 or 60. That's why a very long and drawn-out coughing spell can cause syncope, because you literally raise the ICP high enough to cut off the cerebral perfusion pressure. Now, your brain has the ability to auto-regulate the pressure to itself, and it does that by decreasing and dilating and constricting arteries. And the Monroe-Kelly doctrine says your body will respond to intracranial pressure by expelling cerebral spinal fluid, by draining venous blood out of the cranial vault. And just remember that as ICP increases, MAP is going to decrease. So the Monroe-Kelly doctrine identifies what your body does as a compensatory mechanism to keep ICP low so that it doesn't drop your cerebral perfusion pressure. You know, when you twist your ankle, it's going to swell. When you smack your brain against the inside of the skull, it's going to swell. If bleeding does occur, then from stretched or torn vessels, now you've got the addition of that extra liquid. When the brain swells, there's extra liquid. And the problem with this is that liquid is non-compressible. You know, hydraulics teaches us that if we take a liquid and we put it under pressure, we can literally move buildings. So you cannot compress a liquid. So as the brain swells, there's more liquid. As bleeding occurs, there's more liquid. That decreases the cerebral perfusion pressure because liquid into the brain is going to cause ICP to rise. As ICP rises, cerebral perfusion pressure drops. And so the brain requests more oxygen by selectively vasoconstricting which decreases blood supply to the brain, which is just this vicious cycle that goes over and over and around until herniation occurs. And herniation is a situation where the pressure inside the skull is so great, we know we can't compress the liquid. So something inside that skull has to give. And the only natural place for it to go is out the foramen magnum. The uncus is displaced laterally before moving downward through the tentorial incisura. Now the tentorium incisura just means incision. Tentorium just means tent. That's Latin for tent. So this would be a tent above the incisura. And the incisura is a incision or a hole that allows the brainstem to come out. The tentorial incisura sits above the cerebellum, and it has a hole in it to allow the brainstem to come out. So that's what they're referring to there. In any event, when pressure is put on the brainstem, the oculomotor nerve is compressed by the uncus, and you'll get pupil dilation and contralateral dysfunction of the eyes. So in other words, you've all heard of that person who has a blown pupil. When you see a head injured patient with a blown pupil, that's telling you that you've got that uncal herniation going on, and it's putting pressure on that third cranial nerve. And if we don't do something about it, the brain's going to herniate down onto the brainstem and cause death. When pressure is exerted on the brain tissue, you're going to get an altered level of consciousness. That's the first thing you're going to see. You'll also see bradycardia because the vagus nerve runs directly down along that spinal cord as well, comes out the foramen magnum along with that third cranial nerve. So the vagus nerve is going to be stimulated, releasing acetylcholine. Acetylcholine is going to slow the heart rate down. You're going to see some sort of recognizable breathing pattern, whether it be Cheyne-Stokes, which is shallow, deep, shallow with periods of apnea, or you may even see ataxic respirations. You may see central neurogenic hyperventilation. But in any event, it's going to be an abnormal, recognizable breathing pattern. And that's going to, again, give you a good idea that there's some pressure being put on the brainstem. Decorticate posturing, we know, is when the arms pull up towards the core. That's high brainstem dysfunction. Decerebrate posturing is when the arms extend downward and out. And decerebrate posturing is low brainstem compression. So when you're seeing decerebrate posturing, you know that you've got significant herniation going on. Seizures are likely to occur as well. Now, the role of what we can do for this patient with brain trauma, one of the more important things we can do is manage their CO2. CO2 is a potent cerebrovasodilator. In other words, if the CO2 level is too high, the cerebral vessels dilate. Well, if they dilate, they take up more space, and they're full of blood, which is a liquid, so that's not compressible. So ICP shoots way up when the CO2 level goes high. So it would be really great if we had the ability to monitor end-tidal CO2 in our head-injured patients. And our goal would be to keep it around 30 to 35 millimeters of mercury. Normal is 35 to 45, but at least now the evidence would support keeping it around 30 to 35. Less than 30, the cerebral vessels constrict because you've blown off too much CO2, which could also decrease blood supply to the brain. If you don't have the ability to monitor CO2, then you just need to make sure that you're ventilating at an adequate rate and an adequate depth, which should sufficiently eliminate CO2. Infants, signs that they have a rise in ECP is the bulging fontanelles, the altered mental status, irritability, forceful vomiting, and they cannot open their eyes. In children, they're going to have a headache, stiff neck, photophobia, altered mental status, persistent vomiting, cranial nerve involvement, Cushing's triad, which is that high blood pressure, bradycardia, and an altered breathing pattern. And then you may also see decorticate or decerebrate posturing. When the cerebral cortex and the upper brain stem are being compressed, that's where you're going to start to see changes in blood pressure and heart rate. The blood pressure rises, the heart rate slows. Pupils will still be reactive, but you may see Cheyne-Stokes respirations, and initially the patient may localize or remove painful stimuli. Later, you may see withdrawal, finally flexion, and then when you're seeing, decerebrate posturing, that's a pretty bad sign. However, if we can lower the ICP level by managing their end-tidal CO2, by elevating their head about 30 degrees, we may be able to reverse these effects. Middle brain involvement, wide pulse pressures, bradycardia, blown pupil, central neurogenic hyperventilation, decerebrate posturing, and few patients survive this with normal cerebral function. Lower brain stem involvement, pupil dilation, ataxic breathing, they're flaccid with no muscle tone, changing heart rate, QRS, ST segment, T wave changes, the blood pressure actually starts to drop, and these are non-survivable injuries. The mechanism of injury that can occur would be a force great enough to move the brain inside the skull, rapid deceleration, rapid acceleration. Brain injuries are either primary or secondary or tertiary. Primary brain injuries is the damage that immediately occurs to the brain, and then secondary brain injuries are caused by hypoxia and hypovolemia and hypothermia and rise in ICP. Tertiary brain injuries may result from things that occur outside the brain at a later point in time. Motor vehicle collisions, recreational sports, falls, assaults, firearms, sharp projectiles are all things that can cause brain injury. We already talked about the coup, which is a direct blow, and then a contra coup is on the opposite side. You'll have an injury as well. Diffuse axonal injuries, this is one of the reasons that you might find somebody dead right there. It's the result of a shearing or tearing or stretching force of the nerve fibers with axonal damage. Grade 1, there's transient confusion, no loss of consciousness, but mental abnormalities for about 15 minutes or less. Grade 2 is a transient confusion, no loss of consciousness, mental status abnormalities longer than 15 minutes. And when you get up to that grade 3, there is a loss of consciousness, which could lead to a complete airway obstruction, depending on the position the patient ends up, which could lead to death. Those that survive a diffuse axonal injury may end up with post-concussive syndrome, so they may have, chronic headaches, difficulty concentrating, those sort of things. Excuse me. Again, you can have a moderate diffuse axonal injury leading to, it could be the result from a basilar skull fracture, in which case you might have some focal deficits, and then severe diffuse axonal injuries are not survivable. Focal injuries include cerebral contusion, which is a bruise of the brain itself. You're going to have mental status changes, swelling. Anytime you have swelling, you're going to have a rise in ICP. The skull may be lacerated. The patient may be confused, have progressive headaches, light sensitive, and then all the classic signs and symptoms of a rise in ICP. Intracranial hemorrhage can be epidural, which is arterial. It's a momentary loss of consciousness from a rapidly expanding arterial bleed, and then they regain consciousness and may be lucid when you get there, and then they rapidly decline. That is a classic presentation of an epidural hematoma. Subdural hematomas, that's where the blood collects in the subdural space. It's usually venous in nature. They're also known as subarachnoid hemorrhages, where blood collects between the arachnoid and the pia mater. And in those two types of bleeds, they can be very slow. You may not see symptoms for days, weeks, or months after a seemingly minor bump on the head. Intracerebral is bleeding into the brain tissue itself. That's usually caused by penetrating trauma and is often unsurvivable. So here they're showing you the epidural hematomas, the subdural hematomas, the intracerebral hematomas, and they all carry different mortality rates. They're all treated differently as far as evacuation of the bleed goes. And when you can't say the damage is permanent, you can't say that they aren't going to survive, or we do know what the mortality rates are associated with these type of injuries, but no two brain injuries are the same, and no two people come out with the same outcomes of their brain injury. Everybody is different. So when you have a brain injury, of course it is a life changer. There are going to be some changes. But to what extent, you never know until it plays out. You want to get a history and good physical findings related to brain trauma. If they've got a traumatic brain injury, you have to assume they have cervical spine until proven otherwise. But if I've got somebody with a TBI, they're more than likely going to have altered mental status, and in that case, with that altered mental status, I'd have to immobilize anyway. ABCs, again, brain injuries can cause trismus and lockjaw, recognizable breathing patterns, inadequate breathing, bleeding from the skull could be significant enough to cause hypovolemia, but rarely does. Monitor that abnormal respiratory rate. Remember that when you see a pattern of breathing like Cheyne-Stokes and ataxic and central neurogenic hyperventilation, you put that along with altered mental status and other things, you know that you're herniating. The Glasgow Coma Score is a really good tool. Debatably, it's been used wrong since its conception. It was designed originally in Glasgow, Scotland, to determine the severity, mild, moderate, or severe, of a head injury. So if a patient has a traumatic brain injury and there are no other identifiable causes for their altered mental status, then the Glasgow Coma Scale is a good way to measure mentation. We want to know what's going on inside the head, and that'll give us a good idea. But if the patient's hypoxic, if the patient's hypothermic, if the patient's hypoglycemic, if the patient's hypercarbic, then what we get from the GCS is debatable. We need to make sure that we correct the treatable causes of altered mental status and then score the GCS. Get a good set of vitals, watching for that blood pressure to rise and that pulse to drop, which would be a sign of a rise in intracranial pressure. The number one sign of a rise in ICP is altered mental status. Here are some different breathing patterns that you might see: normal, bradypnea, tachypnea, hyperventilation, sighing. Then you get into here to Cheyne-Stokes, Kussmaul's, Bayat's, and ataxic. Therapeutic interventions: limit your on-scene time. They need a neurosurgeon. Manually mobilize the C-spine. Open the airway with a jaw thrust. Suction. Provide oxygen. Pulse oximetry as well as end-tidal CO2. ECG monitoring to look at the heart rate. Assist ventilations in those patients breathing inadequately. Remember, our goal is to prevent secondary brain injury, and secondary brain injury occurs from hypovolemia, hypotension, hypoxia, hypercarbia, and we can fix all those things. Ventilate them at an adequate rate and depth, preferably by end-tidal CO2 measurement. Because vomiting may be an issue with head-injured patients, oral gastric tubes may be something that can be placed, but it's not something we're going to do in the field. If they do have a GCS less than 8 and their belly's full and you feel comfortable, intubating them may be a good thing to do. If they have any sort of gag reflex, of course, you're going to have to sedate them and then paralyze them. The term RSI, rapid sequence induction, is being replaced with the term RSA, rapid sequence airway, because you still can sedate and paralyze a person and put a King airway in, or put an LMA in, if you're not comfortable intubating that patient based on a variety of factors. You want to gain vascular access and limit your fluids. Certainly if their blood pressure is less than 90, you want to give them a fluid bolus, but in a head-injured patient, their blood pressure is typically going to be high, and we need to leave it alone. That high blood pressure is that way because that's what it has to be in order to perfuse the brain, which tells you that ICP is quite high inside the head as well. So maintain euvolemia, normal volume levels. We don't want to overhydrate them. Check their blood sugar to make sure it's not too low or too high. Elevate the head of the bed 15 to 30 degrees. And you've all been taught on how to remove a helmet. Helmets should be removed anytime they're going to interfere with managing the airway, or if they fit loosely. Restraints would be appropriate, particularly if the patient is extremely violent, which can occur in folks with head injuries. Agitation, violence, those sort of things should be clues to you that you're dealing with perhaps a bleed in the head and hypoxia, those sort of things. So if you do put restraints on, they have to be monitored at all times. Follow your standard policies and procedures. Every service should have a restraint policy. When it's appropriate to apply restraints, what type of restraints you can apply, and what sort of monitoring needs to occur with the patient while you have them in restraints. There we go. Documentation. The reason the patient was restrained, the physician providing online medical direction, the type of restraint that you used, the patient position during treatment transport, what were their vital signs, distal pulses need to be assessed below the restraints, total time they were in restraints, and the patient condition at the time you transferred them to the receiving facility. You can restrain patients mechanically. It takes a minimum of 4 people, preferably 6. When you've got 4 people, you have one take an arm, one take an arm, one take a leg, one take a leg. You have to do it all at once. You have one person who can communicate, have a code word. Shouldn't be get 'em, but have a code word. And when that code word is said, arm, arm, leg, leg, and take them off their center of gravity. You're going to have to hold on to them till you can get a cot underneath them and then strap them or restrain them on a board on the cot. The reason we do that is that if you restrain them to the cot and they have to throw up, now you got a problem because you can't pick the cot up and turn it over sideways. And there's a special way to tie the restraints so that you can quickly untie them. In the event that you do have to roll them up onto their side if you don't have them on a board. Do not place them in the face down position. It's very difficult for them to breathe. There have been, that's called the hobble position, particularly if you restrain their wrists to their ankles. Patients in that particular position have died. When you do have them restrained, keep the stretcher head raised about 30 degrees, again, to protect from aspiration. You can use chemical restraints as well. Just remember that if you sedate them at some point with enough sedation, you may compromise the airway. These chemical restraints can be given IM, they can be given IV, they can be given orally. Of course, if you give them IV, they're going to work the fastest. When using chemical restraints, just like the others, you have to have frequent reassessment. Keep the head of the stretcher elevated at least 30 degrees to prevent aspiration. Okay, so we talked about all the injuries to the head, neck, and face. And if you got any questions, feel free to get a hold of me. Thanks, and we'll talk to you soon.